Hello, 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 everybody, and welcome back to season 3 of Mind Your Body and Soul. Yes, we have completed our first 2 seasons of Mind Your Body and Soul. We thank everybody who has supported us from day one to everybody who's supporting us now and helping this podcast grow. This is the Mind Your Body and Soul podcast, the healthiest podcast that you've ever heard in your entire life. And remember, Mind Your Body and Soul is hosted by myself, Joseph Ward, MT Sweet. And we're an educational podcast that focuses on all things health related to help our listeners learn more about various health topics and information they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. Remember, Mind Your Body and Soul will be available for you every Wednesday on our website at www.nmcpodcast.com, as well as our parent website at www.neighborhoodmedicalcenter.org. Make sure this YouTube channel you subscribe, this video you like, comment, and share. And you can also listen to our podcast on Anchor, Breaker, Radio Public, Pocket Cast, Spotify, Google Podcasts, and it's a plethora of other platforms out there that I'm just figuring out where on. But it's available wherever you need it. So once again, this is another means for us to be able to reach our community within the digital realm because COVID handicapped us a bit. But here we are back and doing our thing in this digital realm. And we will not stop because it's our mission to make sure we have our community members enough information and resources available so they can be the healthiest versions of themselves. All right, Matthias, what's going on, my brother?
Nothing much. Just finishing up them phone calls.
Well, thank you for joining us. Hey, I appreciate your dedication. You double time, you taking care of the patients, and you jumping on here with me. So I appreciate it.
No problem. Anytime.
So are you ready? Are you ready for this podcast today, my brother?
I am. I'm ready to hear about the interesting things with colorectal and everything. So I'm ready. I'm ready to jump in and ask. Okay. You know, I got my question.
So let me give you the setup. So
okay.
About a month or so ago, we were out doing our thing in the community, and then Miss Tiffany Austin, one of my friends, we run into her, right?
Right.
And, I think we were doing COVID vaccines. So we run into Tiffany, we're talking, and she said, "Hey, I have this program. I know you're still in the health realm, and I know you like to talk a lot. So I have this program that I'm working with at FAMU, and we're doing colorectal screenings and working on this within the African American community." So I'm like, well, hey, we have a podcast. We have a means for you to get your information out. I like to talk. I know you don't talk as much as I do, but I know you like to talk to get your information out. So come on and be a part of this podcast. So she was like, okay, now I have a team of people that's coming with me. The more the merrier, because we want to learn as much as possible about this. So we are joined by FAMU's Tune Up program, and we're going to learn about that. Miss Tiffany Austin, Dr. Clement Guede, Mr. Matthew Vargas, and Dr. Kristen Wallace. Welcome to Mind Your Body and Soul.
Yeah, welcome.
Yes. Thank y'all for joining us. All right. So how we always do this, Matthias always has the first question. So I throw it to him and go ahead and get this thing started.
Hey, Joe.
Okay, you know what the first question is. It's always the same thing.
Okay, so my first question is, can you tell us a little about yourselves and what got you into colorectal cancer or the tune-up program?
And that's for all of you.
Oh, yeah. I don't know who to ask first. I don't know who wants to talk or who wants to answer.
We all like to talk, but we'll let Tiffany and Matt start.
Oh, okay. Go ahead, Miss Tiffany. We ready for you. Tell us about yourself and what got you into the tune-up program.
So I'm Tiffany Austin. I'm a native of Tallahassee, and with a background in primarily in like early childhood education. I kind of got into the health realm when I worked with Joe at the Florida Department of Health Sexual Violence Prevention Program. So from there, my bachelor's is in sociology, so I kind of gained the interest in demography and different communities. So I think that's kind of where it started, of just seeing the statistics of just different communities and kind of seeing where I can be of help, of service.
Yeah. Okay. And I definitely enjoyed our time working at the Lynn County Health Department because we were part of our sexual violence prevention program. So definitely enjoyed that time working with you. All right, next.
Okay, thank you to everyone. Thank you for the opportunity to discuss our project, and to my colleagues for taking the time today. My name is Matthew Vargas. I've lived in Tallahassee for most of my life, and also in a little bit in Gainesville and Pensacola in Florida. I first studied environmental science and worked a bit in areas related to sustainable agriculture. But then, I think although I really enjoyed working in that field, I felt that studying nursing and going into the nursing field, would give me new opportunity to work more directly with people, and would just be a good overall experience, in my life. So I think that's what, sort of prompted me to go back to school for nursing. And then this opportunity to work with FAMU on the Tune-Up project came about a year, almost, I guess, a year and a half now ago. And just, I think, an exciting opportunity to join FAMU and, to work in the area of health disparities research. With Dr. Luque, the principal investigator, is not on the call today, but and also Dr. Guede and Dr. Wallace and some other collaborators that we have at FAMU.
All right, thank you.
So, ladies first, Christian.
Oh, great. So I'm Kristen Wallace. Thank you, Clement. I'm Kristen Wallace. I'm a cancer epidemiologist at the Medical University of South Carolina. And I became very interested in studying colon cancer many years ago, and the precursors to colon cancer, in part because it's a very preventable cancer, yet many people are dying from it. And it seemed unnecessary, all these young lives and older lives being lost to something that's almost completely preventable. And so here in South Carolina, I began studying racial disparities, because that's a big issue here, especially in cancer, and noticed that a lot of the young African Americans were dying of colon cancer at very young ages, and it was much worse for the young African Americans compared to the young Caucasians. Although both tragic, felt a need to really try to understand that. At the same time, it became really clear that identifying factors to find these cancers earlier in these patients was really important. And colorectal cancer screening does precisely that, which we'll talk a lot about today, but it helps to identify the cancers at an earlier treatable form, and sometimes even in the precancerous form. So I was so excited when Dr. Luque, who used to be here at the Medical University of South Carolina, invited me to participate with the other tremendous team members in this project, where we're doing an intervention and really trying to make a difference in colorectal cancer incidence and outcomes for patients. So I'll turn it over to Clement now, who's the true expert here. So.
Sure, thank you. And I'm Clement Guede. I'm a senior faculty member at the Moffitt Cancer Center in Tampa, Florida. I'm not from Tallahassee, have never lived in Tallahassee, but my daughter went to FSU.
Oh,
okay. I know where FAMU is. Okay, with that said, my original training is in nursing in the country of Zimbabwe. So I then came over here and did the rest of my higher education in public health. As a nurse, I worked in treating disease at an individual patient level, and I've kind of found it really much more limiting in that regard, and wanted to really disseminate my work to large populations and address the inequities that we see in healthcare, and also inequities that we see in cancer particularly. So these health disparities that Dr. Wallace talked about are really a motivating and driving factor for my work in cancer. And the mission at Moffitt is, as you may already know, is to really contribute to the prevention and cure of cancer. So we truly believe that prevention has a big role in eliminating the burden of cancer and in eliminating these disparities we see that have been mentioned. And to sort of close my intro, I just wanted to sort of really say that there is no better paradigm in which you can say we can eliminate cancer than one that we know where we have a vaccine, such as in HPV related cancers, or in colorectal cancer, where we have screening modalities that can detect it, find it, and help us treat and cure it early. So this is what drives us to do the tune-up program. We want to disseminate this information, this opportunity, this access to screening, so we can prevent the burden of cancer in the Black community.
Okay. And so how did this particular team come together, since you all are in different locations?
Yeah. So you heard a little bit from Matt and Tiffany. They work for Dr. Luque at FAMU, so they are local. And I have known Dr. Luque from when he did his training at Moffitt and at USF College of Public Health. Then he went on to other big and better things, including circle at at Medical University of South Carolina. So we've been colleagues for a long time. I've been studying colorectal cancer for many, many years. So we came together to do this very exciting project.
Okay, cool. But it's exciting because I know colorectal cancer is something we don't talk about at all within our community. I don't remember sitting down as men or just as Black people and having a conversation about colorectal cancer. Mm-hmm. So this is good to get the conversation started.
It is, because mostly they when you tell them what it is and what's the procedure, most of the men first thing is, "No, we ain't doing that." Right. So, y'all already know. So trust me, I'll be like, yeah. Right. So it's just I guess we got to try to figure out how we can educate them to let them know this is something that's serious and it's something that we really need to take part in and do our part to really, encourage other young men and older men to get this done.
Yeah, definitely. So, and this question is directed toward Mr. Vargas. And I know you gave us an overview of what the tune-up program is, but can you kind of go into a little more detail on just the day-to-day dealings with the tune-up program and just exactly how you all really go out and fulfill your mission?
Sure. Well, the tune-up program, the acronym stands for Test Up Now Education Program. So that's how we get tune-up. It is a study that's funded through the National Institutes of Health, actually the National Institute on Minority Health and Health Disparities, one of the national institutes. And so FAMU got this grant, and it runs from 2019 to 2024. Other historically Black colleges and universities and minority serving institutions around the country receive similar funding through this program to address health disparities in minority populations. So this is the larger context, and specifically the project is focused on, the primary objective is to test whether we can increase rates of colorectal cancer screening using the stool-based test. So you'll hear more about the different tests, the different screening modalities that are available, but we're focused on the stool-based test, the one that's typically done at home and mailed in. And we're seeing if we can increase the rate of screening completion amongst African Americans between the ages of 45 and 64 who are not current, not up to date with their colorectal cancer screening according to established recommendations for screening. So that's our target population specifically, and the way or the what we're actually testing is a community health advisor educational intervention. So Tiffany, Miss Austin is the community health worker, community health advisor on the project, and for participants that are randomly assigned to the group to receive community health advisor education, she delivers a 6-week educational intervention, beginning with an in-person meeting, and then follow-up phone calls and text messages. And then the other group simply receives what could be called like a usual care approach. So everyone who participates receives an educational brochure that was developed by the project team in an initial phase that utilized focus groups. So we got information and verified the suitability of educational materials amongst focus group members of the same community, African Americans in that age group. And so everyone receives this educational brochure and the opportunity to complete the screening kit. So they'll receive contact from their health center about receiving the screening kit, which they can do at home and mail in. And so Tiffany deals with or interacts with one group of participants, and then we're comparing that intervention group to the other group, which serves as the control, just receives the educational brochure. So that's the primary goal of the study, is to determine the rates of screening of these two groups and compare them. And secondarily, participants complete an entrance survey, a 3-month survey, and an ending survey 9 or 12 months later, and that allows us to collect other sorts of information about their attitudes, their knowledge, and so we can compare how those may change from beginning to end, as well as between the two groups. And then another component that we're also interested in is sort of determining the cost effectiveness of this approach. So if we learn that the educational intervention that's delivered by the community health worker is in fact effective at increasing screening rates, it might be nice to describe what the cost of that would be to implement. So if a community health center like Neighborhood Medical Center, wanted to implement such a program, say hire a community health advisor, there may be some information from this study that would inform them about what those costs would be.
Okay.
So are all of the participants randomly selected, or is there other processes used to get the participants within the program?
Okay. Participation really, the first, I guess, step in that is recruitment. So we're trying to get the word out. And the health centers are partners in this, research project. And so Neighborhood Medical Center, we also have Bond Community Health Center in town as another partner. And so the two health centers really are integral because through the electronic health record systems, the computerized systems that they have to manage their patient, database, you guys send out messaging that we've developed, to help inform people about the opportunity to participate, and just sort of an intro on what would be involved. And that also provides, a contact number, a phone number, an email for the project. So if they have an interest in learning more about participation and what that involves, they can contact us and receive that information. So it really is, a recruitment effort, and that's a primary means of it, is the messaging that the health centers disseminate to their own clients as people, will become due for colorectal cancer screening. They're able to identify that subgroup, that's due for screening in their system, and then send out that messaging. So that's the main way so far that we've really that people have contacted us. But Tiffany probably could describe some of the additional efforts that are ongoing to help inform people about the opportunity to participate.
Okay. And just another question on top of that. Have you, using the random selection, have you noticed once a person is selected and the person is informed about the program, because we know there's overall hesitancy within the African American community, but within those individuals that are selected, do you normally see hesitancy with those individuals, or are they compliant with the process?
To this point, well, I guess when compliant with participation itself, the actual steps in participation, I would have to say that most people who, and there are a few initial steps we have to do. Consent, verbal consent, we do first over the phone, which takes about 10 minutes. To read that document, and then we set up a time where we can meet the individual in person to do the entrance survey. So there's a couple steps, once they've established this is something they want to do and are able to do, that are performed up front. And then once we get to that point and we meet them to do the in-person entrance survey, at that point they're enrolled in the study and randomized to one of those two groups. And then their participation, proceeds accordingly, in terms of what group they were assigned to. Some will be contacted by Ms. Austin, and others, will simply receive the brochure and the screening kit. And then, we contact them 3 months later to see if they can do the survey over the phone. And then we haven't yet gotten to this point where we're doing, the ending survey at 9 or 12 months. Those our first participants to enter the study will come due for the ending survey in February, March of 2022. So we haven't gotten that far yet, but to this point most people who have taken have actually enrolled have been compliant with the steps, have, if assigned to the community health advisor group, have been able to meet with Tiffany, take that additional step to meet with Tiffany for the educational presentation. And so I think that, so far the people who have joined as participants, seem to be compliant with the steps that are required.
Okay. Okay.
So Joe, that's really the point of the study, right? To see what barriers people have, whether they are assigned to this group or the other, and we will evaluate that, not only their participation throughout, but also whether they do the actual screening, which is ultimately the point of the study, is to increase the screening use.
Right. Okay.
So we'll be looking at it very carefully. Just a great question.
Okay.
Goes into the next question I have for Ms. Tiffany Austin. How is the tune-up program being introduced to the Tallahassee community, and how can the community access the program?
So the community can access the program. We have several methods. I do outreach a lot. So community events that are out, I'm usually out with the flyer. There's also postings at the public libraries, branch locations. We have a radio advertisement on 96.1 and also 90.5. Word of mouth. Yeah, what else are we doing, Matt?
Well, we have an article so far in the Capital Outlook paper.
And then the Mind, Your Body, and Soul podcast. Yes. Okay. Yes. Okay. So those are like the various methods that you guys are using to get the word out about the program.
Right. And as Matt mentioned, the messaging that goes out with the health centers, that's really been helpful for recruitment.
Okay. And so, but earlier I know I had a question, but it looked like you were going to explain like the processing of getting the participants involved. Tiffany.
Oh, so the process is as Matt kind of explained. So once the participants go through their initial survey and consents, the intervention participants, I meet with them and I share the intervention, the educational video with them. And it's really not a detailed process. It takes like 20 to 30 minutes.
Easy.
Very easy. I answer any questions they have. And so as far as I know, you asked a question about compliance. I'm sure, Joe, as well as Mateus, when you're kind of dealing, or you have patients that are at a federally qualified health center, there can be other social issues that come up. So with that, I just would like to say that the community health advisor, I work with you as far as when we meet, how, we meet on your schedule. I try to make myself as available because I know that access to care is an issue. So participants, we try to stay open with our communication with them. And we invite you all to come on and spread the word for us because the recruitment. Yes, the recruitment is coming. I will say, Matt, it's been a little slow, starting out, but it has picked up, and it's really exciting that the participants that I meet with, they really feel as if they're doing something like greater, and because I try to ask each one, what made you sign up, and they say, I just feel like I want to do something for my community. A lot of them mention FAMU once they know that FAMU is involved. They just want to support FAMU. One other reason is a lot of folks just feel like I'm getting to that age where I just need to start taking care of my health. So if any of those things apply to anyone listening, please reach out to the research team.
Cool. And I'm say this now while it's on my mind so I won't forget, but I will talk to you more about it after we get off. But there's an event coming up November 5th, a community event, and you're more than welcome to join us to be able to come out and pass out your information and talk to more people. But I'll follow up with you more when we get off of here.
That's good.
All right. So this is for Dr. Wallace and Dr. Guede. But kind of go into more detail and help us understand what colorectal cancer is and what leads to the formation of the colorectal cancer.
Okay, I'll start this one. The colorectal cancer forms in the colon or the rectum. So this is a long tube connected between your anus and your small bowel. And this organ is lined with cells that specialize in exchange of water back and forth, nutrients, ions. It also provides, a nice smooth surface so that stool can move through easily. Actually, if you put your tongue on the inside of your cheek, those are the types of cells, similar to the types of cells in your colon. So you want it to be smooth and not rough and things like that. Gotcha. Occasionally, things happen where the lining, that smooth lining, gets little nicks in it, and it can create little clumps of cells that can begin to behave in ways that we don't want them to, and they no longer obey the rules of how a cell is supposed to behave. And so they stop functioning normally. So things like diabetes and obesity, sedentary lifestyles, high-fat diets can create an environment in this lining that really irritates it and is always sort of creating an environment which can cause cellular changes. And so sometimes these little cellular changes can lead to a clump of cells sort of growing and proliferating regularly that can turn into what we call polyps, colon polyps. You may have heard that. It looks like, they say, a skin tag you might have on your skin, very similar in the colon. And so when these start to grow, most of them slough off and they don't cause any harm, but every once in a while, they'll continue to grow, and eventually they will become so disorganized that they will become cancer. And at that point, they can invade into your colon, actual colon tissue, and begin to dive down into deeper layers of your colon. And at that point, we call this clump of cells an invasive cancer. It has crossed a barrier in which it now becomes capable of moving not only lower in the colon, but also to other areas in the body, which is really what we want to avoid. So, you know, the benefits of a screening, which we'll talk more about, is being able to identify these clumps or these polyps and these early cancers first, before they begin to grow uncontrollably. And so we can do that through screening. We can also, you know, do that hopefully someday through advising on diet and other things like physical activity and blood glucose control. So a lot of the factors that African Americans have a higher prevalence of are very common and risk factors for colon cancer.
Okay.
No, that's fantastic explanation there. So just a couple of other points. So we don't really know why some of these polyps grow, but that's an opportunity to find them and remove them and prevent colon cancer. So that's one point. The other point being that a lot of the things we do in life to stay healthy, to prevent diabetes, to prevent cancer, to look good physically, are the same things that are good for you in general. So keeping a lean body weight or preventing obesity is good for preventing colon cancer and all those factors. So we really are excited about working in this area because there's a lot of opportunity to bring positive change and prevent or detect cancer early and prevent people from dying from these diseases, was said earlier, prematurely, unnecessarily.
So my question for this particular section is, once a polyp, let's say a polyp develops, and let's say it is discovered or it isn't discovered, how long usually does it take for a polyp to, I guess, the cancer in it for it to be developed fully into a cancerous polyp and spread throughout the body? Like, how long does that process take?
Yeah, no, these are just general guidelines. So, but the general rule is that between 7 to 10 years.
Okay.
So for a normally growing polyp to change into cancer, sometimes there are some exceptions. Some aggressive, cancers can occur. So the testing, then the interval for getting one of the tests, the colonoscopy, that allows the doctors to visualize or see through your colon, is predicated on the idea that if you get a colonoscopy today and you are clean, so to speak, there are no polyps in your colon, then it's okay to go 10 years because of that long period for the development of polyps to cancer.
Okay.
So I have a question. So if, say there is a polyp and you guys remove it, what would be my next step? Would I have to keep coming back like yearly, almost like an abnormal pap smear, or like every 2 years, or what's the process if they do find something? Is it cancerous? Is it not cancerous? Can it be potentially?
Well, I'll take a stab at this first. So basically, there's a set of guidelines that tell patients when they are to come back. So let's assume you have a screening colonoscopy, or you found a polyp through a FIT test and then went on to get a colonoscopy. In this case, how often you come back and whether you come back at all depend on the type of polyp and the number of polyps that are discovered. So some polyps are very common. Things like tubular adenomas or hyperplastic polyps are so common in the population that we don't need people to come back every 3 years or every 2 years. Oftentimes those can wait for tubular adenomas, which are precursors to colon cancer, but very rarely become colon cancer. Patients can wait up to 5 years. For other polyps, which are more aggressive, which tend to be larger, say greater than a centimeter, or they tend to have multiplicity, 3 or more, or there tend to be specific types of histology or high grade, then patients will come back sooner. Often within 3 years is the recommended surveillance for most patients. Occasionally, patients will come in a bit sooner if all of the polyp couldn't be resected at that time. But so overall, how often you come back and whether you come back is due to the types of polyps that they've removed. But important to note that once a polyp, a pre-invasive lesion, pre-invasive precancer is removed from the colon, that polyp never gives that patient any risk of cancer from that polyp. So once it's gone, which is the beauty of screening, because we can eliminate that polyp before it ever becomes cancer. And that's just a very powerful tool. Now, yes, you might be at risk for further polyps, but that given polyp will never cause cancer in your body. So it's really powerful and it works. So we really want people to get screened.
Okay, I have one more question. So if you have a history of colon cancer in your family and you're African American male, what should you do?
Yeah, so that's a category. So there's 3 groups of people in the general population: those that have a history and those of colon cancer in any family member, those that have multiple family members who have had colon cancer, which are the highest risk level, and those that have no history. So depending with which group you are, if you have a strong family history, you need to start screening earlier, at 10 years earlier than the age at which the family member was diagnosed. So if my father was diagnosed at age 40, I should then start to be screened or talking to my doctor at age 30. So that's what African American men and any other individual who has a strong family history should do. In general, though, those other buckets that are less strong history or average risk, we should begin to talk to our providers, whoever you see for your healthcare, as you get into your 3rd decade, about plans for screening for different kinds of cancer, particularly those cancers that can be screened or found early, like colon cancer. So there are many things men and women of African ancestry can do, but there are also many things that everyone can do to talk about it, to have a plan for when to get screened, and to know where you stand in collaboration with your healthcare provider.
Okay. I was looking at statistics on a video earlier, and it was mentioning that colorectal cancer is the 3rd leading cancer within African Americans. But what I really enjoy about this is my view outlook on colorectal cancer was, I thought it was something that plagued African American men more than it did African American women. But looking at the statistics, we're about the same range of being affected by colorectal cancer. And I'm glad I looked at that, because being able to get a fresh new perspective rather than thinking that it only affects men, because I know in my family, I only hear, I hear it from my brother and my father, but I never hear my mother or any of the aunts talking about it. So I thought it was mostly a men's issue. Okay.
Yeah, you make a great point. Both men and women, Black or any other race, can develop colorectal cancer. However, it's slightly higher for Black men than any other group, particularly when it comes to the risk for dying from colon cancer. Mm-hmm. And we don't fully understand those reasons why that is, but part of it may be the idea that I think my man, Mr. Sweet, said that Black men say, I don't even go there, don't look where the sun don't shine, all kinds of things we hear. That may be one of the reasons, because we don't want to go there, so to speak. So I think the main message is both men and women can develop colon cancer. Black men particularly need to pay special attention. Just because we don't get to doctors as often, we don't get examinations, we tend to neglect those kinds of important things.
Yeah.
So that kind of go into the next question, where it's like, can you explain why the tune-up program is kind of like focused on African American population, and what content or connection between African American in colorectal cancer is there to make it be the highest population?
Yeah, no, that is one of the big questions that is being researched today. What we know is that when Black men develop, or actually Blacks in general, when we develop colon cancer, we developed in areas that are different than other populations. So that is why we push screening with a colonoscopy, especially if you can afford to get one, so that you can examine the entire colon. The other part is that we also tend to get the types that are a little more aggressive. We don't understand why that is, and there's a lot of research happening. That being as it may, just because we get something more aggressive does not prevent us from doing the early detection. The odds are equal if you can be screened regularly. The odds are equal if you can detect it early or detect polyps and remove them. So the disadvantage is only if you wait late and you develop aggressive colon cancer, then we may tend to have greater mortality. So our message and our program and Tune Up is trying to change that, level the playing field, get people early to attend to it so that we don't die prematurely.
Okay. So, a question for Tiffany. As you're going out into the community and you're educating people about the Tune Up program, I'm sure you'll get into conversations about colorectal cancer. Like, what are the thoughts and what are some of the conversations that people within the community are having about colorectal cancer with you when you're introducing the program to them?
So, like you all mentioned, there is a lot of stigma. I would say maybe about 50% of the folks may, like if I'm face-to-face, in-person interaction, they assume that I'm talking about colonoscopy. So a major part of the education is letting them know that our screening is the FIT test, the fecal immunochemical test, and that it doesn't involve any invasive procedure. Other conversations are people share their family history with me. You know, I get a lot of involuntary information. I'm here for it. They share their family history. Even I've gotten into conversations about people's diets after they watch the educational video, and you know, they tell me that they like this certain types of food, or they eat lots of fruits and vegetables, and you know, so the conversations are kind of very varied. But I get to kind of understand these people and why they are interested in the program, why they're taking care of their health at this point in time during the pandemic, you know, so we appreciate all of the participants, and it's just really, it's a great program to be a part of.
Okay, I got a question. So you're talking about the fecal stool card, and Joe knows me, I'm always questioning stuff. So how accurate is this fecal stool card? And then what is the next step if while we're in the process and we're here and we do a fecal stool card, how accurate is it? And if do I need to just, oh God, I got cancer because it came back positive, or you know what I'm saying, my mind automatically goes to the worst. So I just want to know, like, what's the next step? Because you talk about the fecal card, then you go to colonoscopy. I need to make sure I know, and people might need to figure out, well, what's wrong? If I get a positive result, is this definitely telling me I got cancer, or is this, no, you know, just preliminary screening just to break it down for the community?
I think Dr. Wallace can take that one, no?
Sure, I can start on this. So I think when we talk about the effectiveness or the sensitivity and specificity of a test, we have to, you know, take into account a lot of different types of factors. So when you test positive for a fecal immune test, what that means is that the test, which is fairly accurate for the detection of colorectal cancer, found something in your stool that suggests that there might be a human blood in that sample. Now, we often hear of lots of, things related to, hemorrhoids causing blood, and all different kinds of things can create situation with, you having blood in your stool. So that's basically what the FIT test does. It just says this is human blood and it's in here. And so rather than getting alarmed about, oh, I have cancer, oh, what does this mean? I think it's a signal to say, okay, this means that something could be going on in my colon. It could be nothing. It also could be that I might have a polyp. Large polyps can bleed. Early stage cancers often bleed, different types of things. So, and, this is, it's just important to get it checked out with the colonoscopy afterwards, but it's not to be feared that, oh my goodness, this is a bad thing that's happening. And I think that that's, almost all the colon cancers detected through the FIT will identify that earlier than if you were to wait. So let's imagine that you did have a positive FIT. That's a lot better than getting that news than waiting 2 years or so where the cancer is spread where it can't be treated. So it might be a little bit alarming, but it's definitely nothing to, you'll just go through the steps and you'll get through it, and then hopefully nothing untoward is there. But if there is, you've found it early when it's treatable. And I'll just say this one last thing. When detected early, it's 95% curable, meaning that cancer itself is not going to kill the majority of patients. Whereas in stage 4, where it's spread to distant sites, the survival at, say, 5 years is about 20%, 25%. So there's big differences in how patients do, versus early stage versus very late stage. So the FIT's going to help pick that up earlier. Might pick up a large polyp. So it's just good to have it done. And we're all afraid of things. It's part of being alive. And this is something that you can do something about, and that's really positive. And it's beatable. It's preventable and it's beatable through these screenings. So just stay positive about it, I think.
Okay.
So this is an interesting analogy. I'm looking here at the name of the study or the program, and it's called Tune-Up. Right. So it really resonates with men particularly. It's like the tune-up for your car. You go in because either you are going regularly or there's something tiny little bit that is not, looking or feeling right. You're going to get information back. You're going to have a decision to make. And most of the time, it's fixable. So the exact idea here, periodically you get bad news, but it's the idea that you can do something early to prevent a problem and save big money down the road. So this is a very good name. Whoever came up with it, men should get it, women get it, we all get it.
Go get your tune up.
There you go, get your tune up today.
Next time I talk to a patient, I'm going to say, did you get your tune up? And I'm just going to start laughing.
Exactly. Okay. So the colonoscopy, which, I admit, I chickened out on my colonoscopy. I'm going to admit it. I'm telling the world, I did. I was supposed to get one last year at the beginning, the first 3 months of 2021. I know my father has had polyps. My brother has had polyps. I was supposed to get some. I chickened out, and I kept telling myself, well, if I keep eating salads and stuff, I'm not going to necessarily have to get it. But okay, I'm going to stop being a chicken and go get my...
Never too late. It's never too late.
Yes, sir. Yes, sir. So the FIT test, the colonoscopy, those are forms of screening. Are those the only 2 means of screening, or are there other means of screening for the polyps in the colon?
Yeah. Well, so we are again very fortunate in colorectal cancer, colon and rectum, that we have multiple tests. They could be categorized as follows: tests that find hidden blood in your stools or stool-based tests, such as the FIT test or the Cologuard, which takes the FIT plus the DNA test. They all are testing for abnormalities in the stool. When we find abnormal results like hidden blood, Then you have to get that colonoscopy, which is the second group of tests that allow for visualization. The doctor seeing through your entire colon and mapping out and checking the condition, that smoothness, the polyps, and possibly removing them during the colonoscopy itself. So the two categories all work. If you can't get a colonoscopy, get any test that you can get. That's the most powerful message here. While colonoscopy is the most thorough because doctors can see and remove polyps, if you are uninsured, cannot get a colonoscopy because you are really, I'm going to say, deathly afraid, for whatever reason, get a home stool test because it's going to help you make a decision and get comfortable with getting a colonoscopy if it's required or needed. So those two groups of tests, in my book, the best test one can get is the one that you can actually get done. It doesn't help us to say, oh, colonoscopy is more thorough when there are all these barriers or things that prevent you from being able to get it done. Get the test that you can get done and get it now. Get your tune up today.
Okay.
Yes.
Well, that kind of, that kind of goes with where I'm thinking, like my father died of colon cancer, so I'm in that predicament as African American male. Still haven't had one. I don't know.
You guys are putting me to shame.
we working on that.
We got to get our life together.
Most healthcare people, saying we put ourselves on the back burner. Don't take care of ourselves, we take care of everybody else. So we in the process. We got that whole work-life balance thing in the process.
I did do the stool test. I did.
Plus, you are still early. So again, I don't know how old you are. I'm old, but
I'm 37.
I'm 38.
Yeah, so you are in that zone where it's not too late to have the conversation, not too late to do the test. You can actually get done. And in some cases, if you're not eligible, your family history will help you because your doctor can then do that calculation we talked about and say, right, yeah, you qualify.
And then my second part of the question is, where can somebody in Leon County, Big Bend area, Area 2B, that's Gadsden, Leon, Taylor, all Madison, all around surrounding counties, where can they go to get a screening done? Like, is there certain places you guys have set up here? Can they come to FAMU? Do they just go to the regular primary? And what if they don't have a primary care? How can they get access to these stool cards?
Well, yes, definitely. If someone already has a primary care provider, they would go to their primary and talk to them about their colorectal health. If they are uninsured, we've partnered with both Bond Community Health Center and Neighborhood Medical Center. I think both of them have sliding scales for people that are uninsured. So definitely reach out to the local health centers first if you don't have a primary care, and they'll get you set up with a provider.
Okay.
I got to add colorectal cancer to my outreach.
Yes. And the one thing to emphasize here is that the FIT or the stool-based tests are much cheaper and more affordable. So there could be your entry into it. So if you were saying, I really don't have the deductible, the copay, the this, the that, these are fairly inexpensive tests. The clinics have them. Every doctor's office, every hospital has them. Widely available.
Okay.
Yeah, just want to add one thing about the FIT test and the other stool test, the Cologuard. These are for what we consider average risk patients. So these patients don't have a strong family history. They don't have any symptoms, no rectal bleeding, no cramping, no diarrhea, and diarrhea and constipation being chronic. So, 2 weeks or more. And so they're meant to be for patients of average risk, whereas colonoscopy is more for patients that either test positive for one of these stool-based tests or at higher risk. Now, of course, African Americans in general at higher risk, so the colonoscopy is an option. But these stool-based tests are very, very good at detecting cancer early, and they're very simple, and they take like a minute, and you mail them off, and most of the time you're fine. So, just to, and you do those annually. So that's, that puts a little bit of burden on the patient. But if you do them consistently, they're very efficient and effective at picking up colon cancer. So just want to add that.
Okay, so I got a question because you sparked something in my mind. So when you tell people that we have to do a colon, a stool card, can you explain what that process is for people who don't know? Because you're saying a stool card, they're like, well, what's a stool card? Like, do I it's myself? How do I collect it? Like, what's the process to kind of make them feel more at ease? Because it's not a difficult process.
Yeah.
Can you explain to the community, like, so they have an understanding of what a stool fit card is? Because I probably should have asked that earlier.
Matt, you want to answer?
Well, yeah, and I don't have the years worth of experience that Dr. Guede and Dr. Wallace have, so feel free to add anything on. But basically, and the perception I have is that these stool-based tests have evolved quite a bit over time and become simpler, quicker, not as gross, perhaps, as maybe they could have been in the past.
There's nothing gross about the mat.
In case that's a concern, we do hear that, one of the reasons for hesitancy, even amongst people, who have contacted us, and are committed to doing it, but say, there's just some, so if that's a concern, I think maybe they're not quite as cumbersome as in the past, perhaps, but the one that we use primarily through this project, the FIT, or fecal immunochemical test, it is just a little card, and it comes with two things that basically look like little plastic paintbrushes, that your kid may do watercolors with, and you just I think the directions say just sort of brush the stool, kind of along with the water that's in the toilet, just get a little bit of a little bit of the stool with a little bit of water, and then you just sort of paint the card a little bit, so you're not really even so much collecting physical amount of stool. It's really just sort of touching it, kind of like that. That's my understanding. And then you just have the card, and it has the little wrapping to put it in, and an envelope to to seal it up in, and then just mail it. It goes straight to the laboratory that does the analysis of it. So there are a couple of considerations, with these. You don't want to leave them in your car or someplace, where it's going to be 120 degrees in Florida or a lot of other places. It could impact the validity, of the effectiveness of the test. And then if you've done it, if you've actually followed the directions and put the sample on the card, you have a small time window that you need to mail that, directly to the lab. You can't wait 10 days or 2 weeks and then put it in the mailbox, because that also could invalidate the results. So there are directions provided with the screening kit that most people would, I think, be pretty comfortable with.
Okay.
Yeah. So let me just add one from a person who has done one of these, actually multiple of these myself, so I can at least know what it is that I'm talking to patients about, but also because I'm in the age group. So it's very simple to collect. The new generation, and thank you, Matt, for talking about the changes over time. This is not your grandfather's home stool test. These are simpler. Most of them are now one sample. You go to the bathroom one time, you collect, and you're done. The old ones, you had to collect bowel movement number 1, bowel movement number 2, bowel movement number 3. And where do I keep it? What do I do with it? Yes, see, these are simple. And they have gotten so good that you don't need a lot of dietary restrictions. It used to be you can't eat red meat. You can't eat or drink anything red because the coloring would confuse the test. These are very specific, like Dr. Wallace said, to human blood in your stool. So they are very precise. So you get the kit, and there are so many varieties. So I appreciate what Matt was saying. There are many different instructions. Some you're asked to poke, others you're asked to brush, but they all get to the same point of collecting a small amount of stool without touching or handling the stool. So there is Absolutely nothing gross about it. The only thing that most people don't do, they don't turn around and look at their stool. I don't
Right.
understand that.
Right.
You should look at your stool after every bowel movement to see if things are normal. And that's all you are required to do here when you do a home stool test. You turn around, you poke, you brush, you put it into the little container, you send it to the lab in person or mail it. Simple. It's that straightforward. But if you go that route, you have to do it every year. If the result is normal, that's kind of a drawback. But it's very easy, simple, convenient, and you have options to mail in. Most places will take mail in. Some places want you to drop it off, but the key is do it immediately, send it in the next day, and you're done. You wait for your results. And so, lesson number one, get comfortable looking back and checking out your stool.
Look back at it.
That got another question. So can you explain to them what colors it's supposed to be and what are they looking for? Because a lot of people are gonna be like, it's just poop. We're gonna be real. They're gonna be like, it's just, what am I looking for? Like,
Yeah.
I see if I eat corn or something in there, it's gonna be in. So you gotta ask the questions of what are they looking at or what should they look for to know if something's abnormal.
I knew you guys are, you ask difficult questions. But anyway, it's an important question. So I think that the key here is normal is different for every person, but there's a range. The range is generally brown. It can be chalky or whitish, then it's spelling out some other problems. It can be dark, tarry, looking like tar, it's spelling out a different kind of problem. It should be gradations of kind of in the brown. And we should all know what our stools look like. That's why I'm making this point.
Mhm.
The second point is when it comes to stool color, how formed it is or consistency. So if you normally go soft and it's now starting to be hard for the last 2 weeks, constipation and those kinds of things, those are all things you should be observing, looking, and knowing about your bowel movement, the regularity by which you go. So there's all kinds of, we could go to school about stool and
Go to
so,
school
so
about
anyway, you ask a very important point. Know your baseline. If it starts to deviate, then talk to a provider about it. It's nothing to be concerned. It's just saying, I got an itch. If it continues, I gotta get it checked out, right? My stool is changing. If it continues, but the beauty with colorectal cancer is we don't have to wait for these changes. We can take these tests and they can tell us a lot.
Okay, I got one more
Okay.
question. Because I eat a lot of stuff I'm probably not supposed to eat anyway. But some of the things that have like dyes and things in it, like sometimes I treat myself and get the snow cone that I probably don't need to eat.
Red velvet cake do it to you too.
But you know what I'm saying? And whatever flavor or whatever color that you eat, it actually looks like that later because of the dyes and stuff. So I do not need to do a stool fit card, especially if I eat something that, well, I would never eat the red ones because I'm allergic to berries. But anything that looks like different things like that, and you come out, it normally comes out that color of your stool. So don't take the test while you eat certain stuff like that, or is it going to be okay because of the dye or anything? I'm just trying to ask for people because everybody go to the snowball man. I'm saying I go there too much, so I just want to know, is there anything, if I eat the dye, do I not need to do the test, or how long do I need to wait before I do that if I eat something with the dye in it?
Yeah, it won't affect the test.
Okay.
So.
Yeah, it's very specific to human blood. It looks
Okay.
for a breakdown of human hemoglobin, so it's quite good. But when in doubt, it's just a matter of a couple of days. So you could skip, a few days if you really are concerned about it, and wait until you've washed it out.
Right. And then another question is, what is the turnaround time for the test? So once I get it, I do the test and I mail it. How long should I wait for my results?
So it depends with the labs. Some people do it in-house, so they may do it the day they receive it. Sometimes it goes to Quest, LabCo, all these other different places. 2-3 days, you should be able to get your results. In general, Again, there's a lot of variations depending with where you go, but it's quick. You get your results either through a phone call, or you pick it up if you are going back to the clinic. It's very quick.
Okay. So at what rate are Americans in general being screened for colorectal cancer, and at what rate are African Americans being screened for colorectal cancer?
Yeah, so that's a very good question, especially now that we are kind of in the COVID era, where all kinds of screenings have really been delayed, deferred, and or are not being done. But prior to COVID, we were seeing rates, the highest rates we've ever seen, which is about 70% across the nation on average. And African Americans are not far behind that at about 67% on average. The bigger issue is, while we can talk about averages, there are some subgroups of communities that are left behind. That's where the problem is. Certain communities, meaning neighborhoods, historically predominantly Black neighborhoods where they've had barriers to accessing care. Those subgroups tend to have lower, and I can't give you a number right now, but it is lower than the national average, lower than 67%, 69%. Florida and the United States are about neck to neck now. The good news, though, is Blacks used to be worse at poor rates of screening. Now we really are catching up as a community, Black men and women, and that's really the good news. So we're making a lot of gains in the screening domain, and hopefully that will translate in gains in reducing deaths from colon cancer. So if you have to take a number, it's about between 67 to 70% is the national average, depending on where the numbers are today with the COVID.
Right. But we've seen an increase. That's great.
Yes, and unfortunately, we have room to go, right?
Yes.
So if you take people who are uninsured, that 67% can translate to 40% because they don't have access. That's why we have these programs that are trying to drive up screening. So what I gave you is a best case scenario. The subgroups of people who are uninsured, unemployed, who have no means, can be as people in federally qualified health centers. The average for that is about 40% in Florida. So you can see the national average is 69, 70%, 40% for these community health centers that serve uninsured, underserved populations. So you already see that gap, and that's what we're trying to address. And that's the bad news.
Okay. So for our last question to wrap it on up, it says, what tips or recommendations would you give our listeners to ensure that all of the information and resources are available for them to take advantage on the tune-up program?
I guess we'll start with Tiffany with that one.
Yeah, so all y'all can answer. We just want to make sure we can understand, or like, what tips would y'all give them to basically get screened for colon cancer?
First, I would, if you're interested in the tune-up program, I would encourage you to reach out to Matthew Vargas. If you see our flyer around, his information is listed on the bottom. If you're not interested in going our route with our study, then just simply go to your primary care provider and tell them that you're interested in being screened for colorectal cancer. Matt, I don't think we've mentioned our incentive. You can mention that as well, too.
Y'all got incentives. You know that turn a lot of people. I got one more question before you talk about saying, how do they get in contact with Matt in case they don't have a flyer?
We're going to come back to that.
Oh, okay.
Okay, well, to the incentive point, thanks, Tiffany. Yes, so I mentioned that people are, enrolled in the study when they complete the entrance survey. So at that meeting, when they do the survey, they are provided the educational brochure, and they're provided with a $20 grocery store gift card. And so that's, the first piece of the compensation. And then if they stay, in touch with us, for 9 to 12 months, as I said, we'll contact them at 3 months to do just a short phone survey. There's no compensation for the phone survey, but then we'll call again about 9 months later and see if the person can meet again, is willing or able, to meet again to do the ending survey. And if they complete the ending survey, they would receive a $30 grocery store gift card at that time.
Okay.
Okay.
Yeah, I'm about to get my tune up.
I'm about to get a tune up too. I'm gonna call Tiffany and be like, I need to get enrolled.
Yes. So, Dr. Wallace, Dr. Guede, do y'all have any tips for our listeners to make sure that they're staying on top of their health and getting their tune-ups?
Yeah, no, I think this is a great opportunity. Like Tiffany and Matt said, if you can do it in this program, if you qualify, you have to qualify. You have to be in these clinics that are participating and meet the criteria. If you can, if you don't, then talk to your health provider. This is a topic of conversation that should be on your list if you haven't discussed it with your healthcare provider, whoever you see for your healthcare, so that there can be a plan for you so that this tune-up doesn't go undone. You gotta get your tune-up.
All right.
Yeah. And the last thing I'd add real quick is, set a date. Maybe it's your birthday. This should be a present to yourself. You're really committing to taking care of yourself, and if done regularly, you can, live a really long life. It'll also help you be more aware of just tuning up your whole body, reducing obesity, getting out there and moving, lowering your high-fat diet to fruits and vegetables and fiber. And, you can really, use this as a spark to, keep yourself on track. And if you fall behind, that's okay. You can get right back up on the horse and start over. So I think it's just about, positivity, moving forward. And it's a real simple thing to do. And pick an anniversary date where you do this every year.
Yeah, that's great. That is great. This was fun, enlightening, educational, informative, all the great adjectives you can throw in there. This was that. But before we shut it down, contact information, starting with you, Mr. Vargas. Can everybody give us, tell our audience that the best ways to contact them? Because let's say somebody sees this podcast and say, hey, I want to have this person on my podcast, or I want to invite this person to come speak here or whatever. So how can people get in contact with you?
Okay, sure. Probably the best way, if it's someone that's interested in learning about participation in the study, you can call 850-766-3976, and leave a voice message if I don't pick up. But I'll get back in touch, and we can go through the eligibility criteria, make sure that the person is eligible, and just clarify anything about participation, and if it's something that the person would like to do, we can meet and do the entrance survey, and then they're in. So my email is another way to get in touch, and it's just Matthew, MATTHEW .Vargas, V like Virginia, ARGAS, at FAMU.edu. So either way, is a great way to reach out to me.
Okay. Dr. Wallace.
Probably the best way to reach me is email. It's my name. They chopped off the last letter, so it's WALLACK Wallach at musc.edu. I can also be reached by phone at 843-876-2432.
All right. Dr. Guede.
So I'm going to go through my agents first, Matt and Joe. they can find me if you can just reach them. But in case you really want to reach me directly, you can reach me at Moffitt. And my phone number there is 813-745-3052. Again, 813-745-3052. We do a lot of cancer prevention education programs, and I'm delighted to talk further about it. The other way is that you can email me at my first name dot my last name at Moffitt, MOFFITT.org. So Clement, CLEMENT dot Gwede, GWDE at Moffitt, MOFFITT.org. But the best way to reach me, find my agents.
Yes. Tiffany.
Probably the best way to reach me would be my FAMU email, and that is TIFINI, the number 1, dot Austin, AUSTIN, at FAMU.edu.
Okay. This was, like I said, I thoroughly enjoyed this. This is how we start off season 3 of Mind Your Body and Soul. This is how we do it. I love the partnerships that we create in the community, because we get to have conversations like this, and we know that quality, caring people are out in our communities, making sure that our community members have access to care and have access to the things they need to help improve themselves. So this is why we do this podcast. Like I said in the opener, we created this because COVID kind of shut off how we go out into our community and serve our community. But it was a gift within the whole, I guess, if you look at COVID as a curse, it was a gift within that, because it gave us a new vehicle, a new lane to be able to use to get information to our clients, to our patients, to our community, and we're able to serve more and introduce more people to those who may not know. So that's why we do what we do. So with that being said, remember that Mind Your Body and Soul is an educational podcast that focuses on all things health related, to help our listeners learn more about various health topics and information they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. Remember, we're available every Wednesday at www.nmcpodcast.com, as well as neighborhoodmedicalcenter.org. We're also here on this YouTube channel, Neighborhood Medical Center. It's the YouTube channel. Subscribe, like, comment, and share this video. Make sure as many people as possible see this video, because we want people to benefit from the information. And we're also available on Anchor, Breaker, Radio Public, Pocket Cast, Spotify, and Google Podcasts. So with that being said, once again, thank you to Dr. Gwede. Thank you to Dr. Wallace, Mr. Vargas, and Ms. Austin. He is Matthias Sweet. I am Joseph Ward. And we will see you guys next time. Remember, get your tune up.
Get your tune up.
Yeah.
Thank you.